Hi, everybody. Thank you so much for being here for our first AAPI event for AAPI Heritage Month. I am very excited and very honored to introduce our guest, Dr. Nadia Islam. She is an associate professor at the NYU Grossman School of Medicine, and I would like to go over her bio really quickly. Nadia Islam, PhD, is an associate professor at the Department of Population Health at the NYU Grossman School of Medicine and the associate director for NYU Langone's, if I'm pronouncing that right, sorry if I'm butchering it, Institute for Excellence in Health Equity. Her rigorous research program, marked by a collaborative approach involving multiple clinical and community stakeholders, focuses on developing culturally relevant community clinical linkage models to promote health equity in disadvantaged communities. Dr. Islam co-directs the NYU-CUNY Prevention Research Center, PRC, and the Community Engagement and Population Health Research Core of NYU's Clinical Translational Science Institute. She is also a lead investigator in the NYU Center for the Study of Asian American Health, the nation's only NIH-funded research center for excellence dedicated to eliminating disparities in Asian communities. She wanted to let me know to please hold all your questions until the end of the presentation, or you can put them in the chat and I will monitor it for you. And without further ado, Dr. Islam, thank you so much for being here. We are very honored and excited. And I will, I don't know what I'm trying to say. Go ahead.
Turn it over to me. Great. Well, thank you so much, Flora, for that very kind introduction. And really huge thanks to the University of New Mexico for the invitation. I'm really always happy to have the opportunity to center and uplift the lives and stories of Asian American and Native Hawaiian and Pacific Islander communities. But I'm especially honored to do so during Asian American and Native Hawaiian and Pacific Islander Heritage Month, and really appreciative that your office is recognizing the month in this way. I've been, I consider myself really fortunate to have been able to dedicate my research career to understanding the health of Asian American and other immigrant communities. And in my work, I develop models to better connect communities to healthcare systems, as well as other systems of care in ways that are culturally and socially meaningful. And I have a particular focus on diabetes and cardiovascular disease. And a central theme in my work has really been understanding the diversity of the Asian American, Native Hawaiian, and Pacific Islander community, and using a community-engaged approach to advancing research in this population. And some of you may have heard JP and I had the chance to chit-chat a little before we get started. And we were reflecting on how very small the health equity world is. Unfortunately, there still aren't enough of us, I think, fighting the good fight. But it also is an opportunity, really, for us to leverage and learn from each other. I really came to this work through a couple of different things. I was born in Dallas, Texas, and my parents were the first Bangladeshi immigrants in Dallas, Texas. They arrived there in 1968, and they arrived, as two immigrant adults, young adults, who are starting a new lives for themselves, really without the material and emotional support of family. And so they really leaned into community and building community. And so my parents were in many ways community builders, and found community spaces like religious organizations, community-based organizations, even places like ethnic grocery stores. Those were really like places of community for them and for me growing up. And I think that really shaped my understanding of how critical a role community plays, and particularly for folks that may feel invisible in other ways. And so that really is a theme through all of my work and shapes the way I think about advancing health equity broadly, and especially advancing health equity in Asian American communities. So I will launch into my presentation, and I do have a slideshow. Are you guys seeing the right view right now? If it's the notes view, I can change it. Someone could just speak up and let me know, because I can't actually see the chat.
We see you.
Yeah.
We see you.
Okay, you do not see. Oh, I didn't share. Maybe hold on a second. 1 second. Share. Okay. Okay, and how about now?
We can see your screen now.
Okay.
I think it's just a little laggy with the presentation mode.
All right, and how about now?
Perfect.
Okay, great. So, the title of my talk today is Advancing Health Equity in Asian American, Native Hawaiian, and Pacific Islander Communities. If not now, when? And the reason that I asked that question is because we're at this really unique time in history, having, I don't know if we can say we've come out of a pandemic, but having gone through a pandemic where Asian Americans were very much targeted in many ways. We've seen an onslaught of Asian American violence. And I think across all racialized and minoritized communities, we've really seen a renewed focus and attention on health equity. And so I do think we are at this sort of critical moment to be able to advance models of advancing health equity for Asian American communities in particular. So I'd like to start with setting the context for any discussion of health equity in Asian Americans, and that's to really discuss two distinct but mutually reinforcing myths that are applied to Asian American populations. The first is the idea of Asian Americans as a model minority. The idea that we are more educated, harder working, higher income, an idea that was referenced in the media as early as the 1970s, as you can see here, and really has been consistently applied and perpetuated across time. The other is the concept of Asian Americans as the quote unquote perpetual foreigner, the idea that we don't belong here, that we're somehow other, that we don't fit in. You'll see here the 1882 Chinese Exclusion Act was the first piece of US legislation that barred a specific ethnic group from immigration and naturalization. And this cartoon from 1879 really depicts the racialized position of both Blacks and Chinese during this period. And this kind of sentiment didn't really, or this really legal activity didn't change markedly until 1965, when quotas for Asian immigrants were increased. And the major components of the 1965 legislation included abolishing national origin quotas and really having a selective preference for one, families, and two, for professional level immigrants. And this last preference really helped undergird the model minority stereotype and effectively kind of erased and reframed the early racism and discrimination and the idea of Asian Americans as foreigners that had existed from the previous 100 years. So, kind of on paper and by law, that's what happened. But what we see is that this notion of Asians as the perpetual foreigner has really continued over time. And this is some media coverage from 2015 that I always share. This is from coverage about the Scripps Spelling Bee, noting two, young South Asian American co-champions. So you can see the headline on the left. And if you look at the social media kind of reaction on the right, you'll see this sentiment of, when is a real American ever going to win? When we never see kind of our people winning. The idea of Asian Americans as a perpetual foreigner has certainly been reinforced during the pandemic with references to COVID-19 as the Wuhan or Chinese virus, really resulting in xenophobia towards individuals of Asian descent, and of course, an increase in hate crimes. These attacks have been persistent and pervasive. And you'll see some of the headlines which are very familiar, unfortunately, to all of us here, the tragic massacre of 6 Asian women in Atlanta on March 15th in 2021, as well as the increasing number of hate crimes against Asians really across the country, but most notably in New York City, where I am, including, really the very recent murders of Christina Yuna Lee in her own home, Elisa Guo on the subway. This has been started to be tracked through a number of advocacy organizations. What we know is that upwards of 2 million Asian American adults have reported experiencing anti-Asian hate since the onset of COVID-19, including 1 in 8 Asian American adults in 2020, and about 1 in 10 in the first quarter of 2021, but I think that number has gone up. And this is kind of increasingly being investigated and understood in the public health literature as well. So most recently, I didn't include this on the slide, but Strassel and colleagues conducted a nationally representative online survey of 5,500 Americans to kind of understand the prevalence of COVID-19 related discrimination. And they did find that all racial and ethnic groups were more likely than white adults to experience discrimination related to COVID-19, but that Asian Americans, as well as American Indian and Native American adults, were the most likely to experience such discrimination. So why is this? And this is some of the data from AAPI Hate, the group that's tracking hate crimes across the US. So why this context is important is because it's both driven by and results in the lack of data equity in Asian American and Native Hawaiian and Pacific Islander communities. So data aggregation within and across Asian Americans and NHPI population, which lumps together more than 30 unique ethnic subgroups, renders our communities invisible. A recent American Medical Association Center for Health Equity report on AAPI communities noted, what is measured is what is valued, what is undercounted tends to be counted out. And what I'm going to do over the series of the next few slides is lead us through some illustrative examples. I'm really going to focus on the Asian American community, which is, I am Asian American and much of my work is in the Asian American community, but I'm also going to pull in some NHPI data to really highlight differences across Native Hawaiian and Pacific Islander communities as well. And what I want to underscore through all of this is, and my colleagues and I have highlighted this in a recent Health Affairs article, which I included here, is that there's really a mutually reinforcing cycle of poor data quality on the one hand and racialized stereotypes on the other that really shapes our understanding of Asian American health. So what is, I think, frustrating for many who are working with and in Asian American communities is that our invisibility as a community is happening despite the fact that Asian Americans are the fastest growing minority group in the US. By 2050, it's projected that there will be over 43 million Asian Americans in the US, representing 10% of the US population, and really doubling in size from where it is today. In recent years, migration from Asia has overtaken migration from Latin America. And from 2000 to 2010, this is a little bit old data at this point, approximately 3.5 million immigrants arrived from Asia. So the Asian American population has grown by more than a third in size compared to 6% of population growth among Asian Americans. We also see growth in the Native Hawaiian and Pacific Islander community that's demonstrated here. So we often talk about AAs and NHPI community as this umbrella category. And what we know is that there are really many different groups that fall under both of this sort of large umbrella. Asian Americans experience both geographic concentration and dispersion. And some of that is demonstrated here. More than half of Asian Americans live in 4 states, in California, New York, Texas, New Jersey, and Washington. There's also a growing population in New Mexico. And among NHPIs, more than half live in 2 states, in California and Hawaii. And you can see that there are large pockets across the country, and really significant differences in geography emerge when you disaggregate further by ethnic subgroups. So for example, I mentioned my family is Bangladeshi. 48% of Bangladeshis live in New York, the New York City metropolitan area. And then at the other end of the spectrum, the top metropolitan areas, for example, for Nepali or Laotian Americans account for just 6% of their total population. So there's sort of this simultaneous dispersion and concentration really across Asian Americans as a whole and within particular subgroups. So we know, from ample kind of census and other data that the Asian American community is growing. Generational status of Asian American populations is also influenced by these trends. So 57% of Asian Americans are foreign born. More than 80% of Asian Americans in the US today are first or second generation immigrants. And what that really indicates is that the Asian American experience is really inherently an immigrant experience. When you are able to look at the data disaggregated, you really see a lot of variation in nativity, with lower proportions, for example, of foreign-born Japanese communities, and in some communities, like you can see here, the Indonesian or Bhutanese community, upwards of 75% or more are foreign-born. We see similar variations in Native Hawaiian and Pacific Islander communities, with more Native Hawaiians born in the US and other Pacific Islander groups more likely to be born outside of the US. So thinking then, moving on to education. Educational attainment is really, going back to kind of the myths that I was talking about earlier. Educational attainment is kind of a central dimension of the model minority myth for Asian Americans, that Asian Americans are uniformly better educated than other groups. And aggregated data, as you can see here, does show that Asian Americans do indeed have higher rates of educational attainment than other groups, as well as compared to the national average. But when you look at disaggregated data, a very different picture emerges. And it's, I really just want to call your attention to differences across Asian American groups, as well as between Native Hawaiian and Pacific Islander groups. Similarly, when we look at something like income level in the aggregate, we see that Asian Americans look like they have, as a whole, higher income levels compared to other groups in the US. But then when we look at it disaggregated by subgroup, we see tremendous variation, with several Asian American subgroups living far below the poverty level. Similarly, we see a very similar looking trend in terms of understanding disaggregation and its impact in Native Hawaiian and Pacific Islander groups. And so understanding these differences, and the reason I kind of highlighted factors like education and income, because one are these issues tend to cluster in certain communities, as you can see here. And they're really critical to understanding health equity, because, as we know, education and poverty are really key determinants of health. Related to immigrant and generational status are issues of language access and limited English proficiency. And this is an area where both Asian Americans as a whole, so looking at data in the aggregate, but also particular Asian subgroups, have really high levels of limited English proficiency. About 30% of all Asian Americans, but up to almost 80% in some communities, experience limited English proficiency. So, that's sort of a demographic overview to give you a sense of why data disaggregation is so critical. And similar to the sociodemographic profile of this diverse population, when it comes to health disparities, there really isn't a one-size-fits-all approach. A major challenge to research in Asian American communities has been that Asian Americans are and continue to be the most understudied US racial and ethnic minority group. There have been a couple of analyses now done of federally funded research, as well as publications that have been generated on Asian Americans. And kind of a landmark study that was done between 1966 and 2000 found that only 0.2% of research studies included Asian Americans. That same analysis was conducted in 2018, and we found that though the number of grants on Asian Americans, federally funded grants on Asian Americans, has increased since 2000, the proportion still remains the same. Similarly, an analysis of kind of Medline and PubMed articles generated on Asian Americans reported only 0.01% of articles included any Asian Americans at all in their study sample. And this plays out directly in terms of programs and policies for Asian Americans. So for example, in New York City, which is home to the largest concentration of Asian Americans in the US, only 1.4% of the New York City social service funding is directly allocated to Asian American communities, which now the community makes up almost 18% of the total New York City population. So, we have a data problem. We have a problem with, a lack of allocation and attention to the community in terms of resources. Despite this, despite the sort of gloomy picture that I have presented so far, there's really been tremendous momentum in the last, in particular, 10 to 15 years. And this is really going to be reflected in the following data that I'm going to present to you to give you sort of a key summary and overview of disparities faced by Asian American communities. So what I want to do in the next section and the next few slides is highlight what we know about Asian Americans, both in the aggregate as well as disaggregated by subgroup where data was available. And I'm going to focus on kind of my research area, which is cardiovascular disease and diabetes, because I also want to share some of the models that we're using to address these disparities and advance health equity in particular Asian American communities. So let's start with hypertension. Nationally, it appears that Asian Americans have lower rates of hypertension compared to white populations, but we see from this data, this is data from the National Haynes study, we also see that their rates of being on medication for treatment, even when diagnosed, are lower compared to white populations. This is also reflected in other minoritized groups. So that's in Asian Americans as a whole. But not surprisingly, when we do disaggregate data by subgroup, we see that rates of hypertension vary substantially among particular groups, with high rates among South Asian, Japanese, and specific NHPI communities, and among the highest rates in the country compared to all other racial and ethnic groups in the Filipino community. In the same study, the authors investigated how CVD risk kind of clusters in Asian Americans by subgroup as well as risk by gender. You can see that on the right. And importantly, we see that the risk for CVD is highest among Filipinos and NHPIs, both men and women, compared to aggregated data. So that's hypertension. Thinking about diabetes, our understanding of diabetes in both Asian Americans and NHPIs is a little different in that even in the aggregate, even when we're looking at sort of this umbrella category data, we see that Asian Americans have higher rates of diabetes, both diagnosed and undiagnosed, compared to all other racial and ethnic groups. When we're able to further break that data down, as you can see on the right, this is a JAMA analysis that was conducted a few years ago, we find that some groups are at lower risk, for example, East Asians, compared to South and Southeast Asians. This has kind of been demonstrated again and again. This is some regional data from a sample of about 1 million patients in the Kaiser system in Northern California. Again, found that rates of diagnosed diabetes were among the highest among NHPI, South Asian, and Filipino groups. And moreover, when we look more granularly by geography and subgroup, diabetes disparities within and across communities is really made even more stark. So this is some data that our group at NYU generated through something we call the Health Atlas. And this was really a comprehensive data effort across 2 national, 5 state level, and 3 city level data sets that we conducted in partnership with our National Advisory Committee. That National Advisory Committee is composed of both researchers as well as community groups. And we were able to harmonize and bring together that data, really reporting prevalence estimates for over 22 health behaviors and risk factors, ranging from very small to larger NHPI and Asian American subgroups. And so I'm just kind of sharing one piece of that Health Atlas in terms of diabetes. And you can see that what we've seen from regional data as well as national data is reflected nationally, is reflected across geographies, and that there are some key differences across particular subgroups. What's important in terms of understanding diabetes and cardiovascular disease risk more broadly in Asian Americans is that Asians share diabetes risk in Asians shares a unique relationship with body mass index. And so there's now been a large body of research, both internationally as well as in the US, that have noted this unique profile of BMI risk for Asian Americans, namely that Asian Americans develop diabetes at lower BMI rates compared to other racial and ethnic groups. And what these findings really underscore is the need for tailored guidelines. So in response to this, the American Diabetes Association issued a position statement a few years back now and launched a campaign called Screen at 23 that was really aimed to revise guidelines regarding early screening for Asian Americans into clinical practice. So, really identifying Asian Americans who are at a lower BMI at 23 and start screening for diabetes at that rate. Despite what we know about enhanced risk, Asian Americans are less likely to be screened and more likely to have undiagnosed diabetes. This is some national data, and I apologize, the citation's not here, but this is a JGIM article from a few years back using NHS data. And what we know is that these disparities extend not only to prevalence in both diagnosed and undiagnosed diabetes, but also to management. This is some analysis we did of New York City data collected by our city health department. And we examined disparities in diabetes management by ethnic subgroup. And as you can see here, found that particular Asian subgroups have poorer self-management compared to other minoritized groups. This includes things like engaging in weekly glucose checks or daily feet checks. But we also found that they're receiving less provider level management that aligns with, for example, American Diabetes Association standards of care. So things like receiving regular hemoglobin A1C checks or regular foot checks. So really underscoring the need for not just kind of patient level education, but also systems and provider level interventions and change. So importantly, thinking about our current context is very important because it may exacerbate already known risk factors for diabetes in Asian American communities. This is some primary data that we collected during the last 2 years in a sample of 1,200 diverse Asian subgroups in New York City. And we found, and the purpose of this, and it was done in partnership with our community-based organizations, was really to understand and amplify the key challenges that Asian American communities were experiencing as a result of the pandemic. Some of the key issues that were raised is we found more than half reported trouble accessing food or experiencing food insecurity. And an astonishing 80% of individuals in our sample reported that they feared for their safety during the pandemic. We also know from other work that there's been a huge economic impact, particularly among Asian American small business owners. So what all of this data really underscores is the need to understand the role of anti-Asian discrimination in exacerbating access to health promoting opportunities, as well as kind of their role in influencing the management as well as development of diabetes in Asian American communities. Just checking on the time. I wanted to share a little bit of data on kind of non-CVD risk factors, although CVD and diabetes research are kind of my passion. Cancer is another major disparity area for Asian Americans. In fact, cancer is the leading cause of death among most Asian American groups, as well as the fastest increasing cause of death among Native Hawaiian groups, as well as certain Pacific Islander groups, such as Chamorro. Like the message I've been sending throughout the last half hour, there's really a critical need to contextualize disparities by subgroups. So for example, if you look at this data, it's not surprising that heart disease is the leading cause of death among South Asians, Filipinos, and NHPIs, but we can see the cancer impacts in other groups like Chinese and Korean communities. In this next slide, I present some of the rank and percentage of the top 5 cancer sites by ethnicity. And, I think the takeaway from this is while there are commonalities in some of the top cancer mortalities, for example, lung cancer for Asian men, there are also some differences in terms of, we see differences in cancer mortality among women by ethnicity, and, underscoring again some commonalities such as liver cancer burden, reflecting really the burden of hepatitis B in several communities, including the Chinese and Vietnamese population. So similar to some of the findings that I presented on diabetes, there's some clear access and health system barriers driving cancer disparities in Asian American communities. So this data here shows some screening rates for several types of cancer. And you can see that they remain suboptimal in Asian Americans as a whole, really looking across different types of cancer screening. So finally, it's really impossible to have a discussion on health disparities and I think more importantly, equity without acknowledging kind of the world's largest public health crisis. There's been really, I would say, a shameful lack of national policy attention on the impact of COVID-19 in Asian American communities, despite the fact, again, that there is ample evidence that COVID is disproportionately impacting Asian American communities, particularly compared to white populations. So an analysis by Chu and colleagues, this is an analysis of National Health Statistics death certificate data, found disproportionate burden of COVID among Latinx and Black communities, but also for Asian American and Native Hawaiian and Pacific Islander communities. And a number of other studies have really demonstrated similar findings. For example, there was a systematic review of 18 million patients across 50 published studies that found Black and Asian individuals were at higher risk for COVID-19 infection compared to white individuals. And in 2020, more than 13,000 Asian Americans died than usual, really representing an almost 40% increase over the prior 5-year average. And again, when we examine by subgroup, an even clearer picture emerges. So this is some of the data I was highlighting earlier. But this is an analysis that we did in New York City. We analyzed data from 85,000 patients in the New York City public hospital system called Health and Hospitals. And this was specifically from the period when New York City was really the epicenter of the pandemic. And we applied an innovative methodology to better identify both Asian American patients and Asian Americans that have a particular subgroup ethnicity. And what we did was apply a surname matching methodology to really better identify patients by ethnicity. And when we did that, what we found is that South Asian patients had high rates of COVID test positivity, second only to Latinx patients, also high rates of hospitalization, second only to Black patients. And I think one of our most surprising findings was that Chinese patients had the highest mortality from COVID after controlling for age and gender. And again, this was in the period when New York City was the epicenter. Many of our New York City public hospitals are concentrated in Asian American serving communities. I think, Elmhurst Hospital in particular became quite infamous during the epicenter of the pandemic. It was serving many Asian American communities. And this analysis really came as a result of inquiries from frontline providers in the health and hospital system who came to us saying, we are hearing a lot about the disproportionate impact of COVID in communities of color, but we are not hearing about the particular impact in Asian American communities, and we are seeing them in our wards and in our hospital. And so this analysis was particularly important for kind of shining a light and filling that gap. So that's a little, I know it's a bit of a whirlwind tour. It's always hard to distill everything into an hour talk. And I think, what I hope you took away from the overview that I just provided is that there are some key challenges to data in terms of data being aggregated across Asian Americans and sometimes across both Asian Americans and NHPI communities, but that there has been tremendous momentum in the last 10 to 20 years. And through that momentum, we've really been able to clearly articulate that across specific Asian American subpopulations, there are some key disparities that are being faced. So what I'd like to do now is to kind of share the approach that we've used to both building a research agenda, but really using that research agenda to advance the health of Asian American populations. We're coming out of a context right now where the term trusted messengers has sort of become this common refrain, right? During the pandemic, all we hear about are trusted messengers. But I really like, Giselle Corby-Smith wrote a commentary, I guess a few months back or maybe last year, and she wrote, engaging trusted messengers can really only happen in the context of true partnership with communities. And this has really been a cornerstone of our work at the NYU Center for the Study of Asian American Health. We refer to it as CISA. The CISA was founded in 2003 with funding from the National Institute of Health, from the National Institute of Minority Health and Health Disparities, NIMHD. And we remain the only NIH-funded research center of excellence committed to advancing health disparities in Asian American community through research, training, but most critically, partnership development. And that's our mission. What we have developed to kind of operationalize and move our work forward, really kind of our sort of guiding principles, is this integrative framework to implement research in Asian American health. And it really, what this framework provides for us is a guide to addressing underlying structural biases and kind of racialized stereotypes, to really think about how we can make systems change in Asian American immigrant communities to achieve health equity. And some of the key strategies that we use in our work are kind of listed here. I'm not going to go over them. But I think overlaying this framework is a community engaged approach. And community engaged research has really been central to our work. In the last 20 years, I think researchers, funding agencies, but probably most importantly, communities have really spearheaded the challenge to make research more relevant through meaningful engagement of stakeholders in the process. And I think what that has done is kind of enabled a paradigm shift in our understanding of who is the expert in any scientific endeavor. But I think what we know and have learned about community engaged research is that there really is a spectrum of the work. And on one end of the spectrum, on the right-hand side, is kind of the idea of community-based participatory research. I'm sure many of you in the audience use CBPR in your work and are familiar with this approach and framework that CBPR really calls for the promotion of active collaboration and participation from communities at every stage of the research process, really integrating a co-learning process throughout research implementation, making sure research and interventions are community-driven, and that results are disseminated in action-oriented ways. What we found in our work in Asian American communities is that CBPR in particular has served as a really useful framework for engaging communities that very much face, as I described, a legacy of structural and cultural exclusion from the public health enterprise. They continue to face that. And what CBPR has been helpful in is kind of has given us the opportunity to work with community to develop innovative ways to highlight the unique health issues that our communities face. Was there a question? I can address it now. Okay, if not, I'll keep going. So community-rooted partnerships have played an especially critical role for Asian Americans, kind of given this current context of Asian American hate incidents, language access challenges, and really underlying assumptions by both local and national jurisdictions that Asians are not at high risk. We've seen that in sort of the COVID dialogue, that Asian Americans, often are not included in analyses on kind of COVID disparities. And so those partnerships, for us, two key players in making those partnerships, to actualize those partnerships have been both, partnerships with community-based organizations, frontline serving CBOs, but also with community health workers, or CHWs. And CHWs are an approach and a model and a workforce that we really engage a lot with in our research and our work. So CHWs are trained public health professionals who have a close connection with the communities that they serve based on shared life experiences. They're referred to by a number of names: promotores, community health representatives, and patient navigators, and other terms. They have really a very established scope of practice, which is broad, but I think most critically leverages their strengths in community connectedness. So fundamental to a community health worker ethos is a capacity building approach. CHWs aren't telling communities what to do. They're not diagnosing medical problems. They're also not taking the place of your medical team, of a primary care physician, but instead they're working to motivate and enhance self-efficacy. Also really fundamental to this, to a CHW model, is an assets-based approach. For us, working with and engaging CHWs has come out of a recognition that our communities have leaders and strengths. And that inherent strength and leadership can really be leveraged to improve health on the individual level, but also on the community level. I think there's some broad literature supporting the effectiveness of CHWs now. Working with CHWs has demonstrated health improvements across a range of health issues. And I think, the CHW approach has the potential to improve access to healthcare resources, improve quality and cultural appropriateness of service delivery. CHWs can work to organize individuals across communities that can help play sort of a negotiation role between communities and the healthcare system. So for me, that is the best way to understand CHWs. That's to use the metaphor of a bridge. CHWs help bridge the gap between communities and the healthcare system specifically, but also communities and other systems of care. So what I'd like to do in the last, I say I have about 15 minutes, and I want to leave about 5 or 10 minutes for questions. I kind of want to go through a case study of a particular project that we implemented at NYU to give you a sense of how we've worked with community health workers and with community more broadly to really drive change. So the study I'm going to tell you about is called the DREAM Project. The goal was to develop, implement, and evaluate a community health worker-led intervention designed to improve diabetes control in the Bangladeshi community. And this was very much a community-driven project. It emerged because we were approached by both community partners who came to us and said, we are seeing a lot of this problem of diabetes in our community. And simultaneously, we were approached by the healthcare team at Bellevue Hospital. So Bellevue is New York City's largest public hospital. It's also NYU's teaching hospital. We were approached by primary care physicians there saying, we have seen a huge increase in the number of Bangladeshi patients who are coming to our primary care clinics. Almost all of them seem to have diabetes, and there seem to be kind of cultural issues that as healthcare providers, we do not understand how to navigate. There were some issues around kind of language barriers and language access, but also other kind of cultural issues. And so we came together as a coalition, actually, including representation from our healthcare partners at Health and Hospitals, but also a broad coalition of community-based organizations, cultural organizations, other types of faith-based organizations, as well as ethnic media that were serving the South Asian and Bangladeshi community. And we came together to kind of address this challenge. It began with doing some both qualitative as well as survey formative work in the community to really identify what some of the key challenges as well as kind of assets and strengths were in the population. And then we used that data working with the coalition to kind of propose a model for addressing the challenge of diabetes and diabetes management in particular in the Bangladeshi community. And so the model that we came up with, really with input from our coalition, was a community health worker model. And that really came out of a discussion from community partners noting that, yes, there are many barriers that the Bangladeshi community faces. It's a low income community. In terms of workforce, they tend to be kind of segregated into low wage service sector jobs, things like taxi driving, restaurant work, vendor work, et cetera. But there are also some really key strengths in the community in terms of community being very family centered. It's a very kind of, it's a community with a lot of social support. And there are these models of kind of lay leadership from the home country that were brought over that could really be leveraged and recognized in the work that we were trying to do. And so we implemented a CHW-led study using a randomized control trial design to test its efficacy, where Bangladeshi individuals with diabetes were randomized into either a treatment group or a waitlist control arm, and individuals in the treatment group who had uncontrolled diabetes received 5 group-based, culturally and linguistically tailored CHW-led sessions on diabetes management, as well as some one-on-one visits from the community health worker to their home, and the control group received just the first visit. So that was kind of our study design. But But I think what was really important is our coalition really recognized that important contextual determinants were impacting health in our community. And so they really challenged us to design the intervention, to really think about how we could use the CHW model to shift context and opportunity for community members. So they really encouraged us, without using the term socio-ecological model, they really encouraged us to use the socio-ecological model to drive the intervention's impact, not just across the kind of individual level, but also across communities and systems. I'll just share a couple of examples of how we did that. You know, at the individual level, what our CHWs did was really provide culturally tailored health education. So that involved, yes, you know, tailoring and adapting a curriculum to be delivered in Bengali, but also to make sure that it was culturally responsive, that it was, you know, clearly kind of food, exercise are very critical components of diabetes management, thinking about delivering those in ways that were culturally and socially responsive. And I'll just provide an example of how they did that. The kind of green image that you see on your right, that's the cover of a DVD. I know DVDs are kind of like dinosaur items now, but this was, you know, about 20 years ago. And what our CHWs learned from our participants is that, particularly our female participants, is that one, they felt like they didn't have safe spaces to exercise. Two, they were in very small New York City apartments and often were in multi-generational homes and needed something that could be conducted in a very small and tight space. Three, that you know, there were socioeconomic barriers to participate or to things like gym memberships, but also that there were kind of cultural and religious barriers. This is a predominantly Muslim population, and many women in particular felt that it wasn't appropriate to be engaging in physical activity in spaces outside the home. And so our community health workers actually developed an in-language, 30-minute, very simple physical activity DVD. This is written in Bengali, but it's called 30 Minutes for Your Health. It really encourages the use of everyday household items that can be used, you know, to engage in physical activity in simple ways, in kind of cramped small spaces, and incorporated this into their curriculum working with women. So that's the type of kind of culturally tailored health education that our CHWs were providing. But kind of moving upstream, our CHWs also worked at the community level. And here, you know, kind of their roles as leaders were really important. So I now have a team of about 20 CHWs. You know, almost none of them come from a health background, but almost all of them have some type of community organizing background. And that includes, you know, organizing immigrant workers, it includes organizing in faith-based organizations, some were student activists, and it's that kind of known status of them as trusted leaders where they're able to connect to organizations to kind of really think about how can we change community context to be more health promoting. So for example, our team works with ethnic grocery stores and restaurants to do product placement of healthier foods. They've worked with the city and with faith-based organizations to implement things like play streets or culturally appropriate types of physical activity opportunities. And then also thinking about, you know, culturally relevant activities. So for example, in South Asian communities, cricket is a very popular sport. So implementing things like cricket leagues or walking clubs, things like that. And then finally, at the systems and policy level, those of you who have worked with, you know, both community advocates, but also with CHWs, know that they are very powerful storytellers. And I think it's often stories that compel our policymakers to make needed change. Data is important, but data is nothing without the stories. And because our CHWs are really, one, have the lived experience of being from the community, but are really working with community members to address a wide range of issues, they can play a really important role in advocacy efforts. And our CHWs have been super active in both local, statewide, as well as national policy efforts to make our health systems more responsive. So I'm not going to spend too much time on this. You know, what we were able to demonstrate with our study is kind of feasibility in terms of high study retention. We also were able to demonstrate efficacy of the model in terms of achieving hemoglobin A1C control, as well as reduction in hemoglobin A1C from baseline to study follow-up. But again, I think the stories are what's most compelling. These are some case notes from one of my community health workers. This is a participant who initially felt really uncomfortable going to the hospital for her regular visits, to maintain her diabetes. And really the CHW worked with her to, teach her how to read a subway map, to kind of encourage her and empower her to be able to take the subway on her own, to go to appointments on her own. And this participant in particular became a really active advocate for the program, sent a lot of referrals our way, and actually is now kind of a volunteer in the program as well. So what I want to end with is just to note, what we did with DREAM was kind of test a model for equity, but we know that to truly impact health equity, it requires dissemination, replication, and scale. And I think the community engaged process that we have used has provided the context to do those things in a number of ways. The first is that, we, as I noted, we had a coalition that was guiding our work. That coalition has really expanded to include representation from diverse South Asian communities, and has really expanded to work in many other health areas beyond diabetes and cardiovascular disease. At our institution, building on our work, we've established a CVD and diabetes research track. And we've supported the replication of this CHW model to other communities. We also have created a publicly available toolkit, and have really been active in disseminating this model through the media. So you can see, I think it's on your screen. Yes, this is an example of a media from, an article from MarketWatch, kind of highlighting the unique role that CHWs play in kind of addressing the social determinants of health. So I do have a couple more slides, but I see we're almost out of time and I don't want to keep anyone, and I also want to leave a little bit of time for questions. So I'm just going to end there. Again, really appreciate the opportunity to highlight some of the key issues facing the Asian American community when it comes to health, and also thinking about potential models to address health equity for this population. So I'm going to end there and stop sharing my screen, and really happy to take and address any questions.
Wow, Dr. Islam, that was absolutely amazing. And it actually made me a little bit emotional because my parents are immigrants as well. And I know how much they've struggled when we first got here. And I think everything that you're doing is absolutely amazing. And I just wanted to thank you. And also, we do have a couple of questions in the chat. If you all have, a meeting at 1 or another commitment, sorry, but we will continue. And if you can stay, please stay. If you can't, we totally understand. Dr. Sanchez had 2 questions. One was, what has been your approach to engage college and post-bac trainees interested in AAPI health?
Yeah, that's a great question. And I didn't talk too much about the kind of training component of CISA. But I think it's been really critical. So we have something called the Health Disparities Research Training Program, and we support both kind of very structured semester, summer, and year-long internships for Asian American, in particular Asian American students. We don't get a lot of PI students, but Asian American in particular, really across the pipeline. Starting mostly from high school, but I think that the majority of our students are college and kind of master's level students. We also work with medical students as well as doctoral students. And what that's looked like, we really try to shape the experience and internship according to the student's interest, with an emphasis on enhancing their experiential learning and community engaged research. So that sort of looked like a number of things. For some students, it's really being in the field with community health workers, or in implementation, it could be data collection. In some instances, it's kind of data analysis of both quantitative and qualitative data. And then in particular for our medical students at NYU, we've been working with our first year students, and we have a curriculum called the Practice of Medicine that has kind of a focus on social determinants of health for the first month or two, and we've incorporated learning objectives around health disparities in Asian American as well as other communities.
And I think,
sorry,
go ahead.
I have a quick question. Thank you for the talk. Very interesting. So when you started your talk about the Asian community being referred to as the privileged minority. Perhaps you don't use that terminology, but people have used that terminology, and I've heard it. How do you handle that, and how do you deal with it? How do you explain a person that we are not part of privileged minority, but this is what we are?
Yeah, it's a great question. I think it's a hard thing to respond to in the moment, but I think the way that we have approached it is to respond with data, and I think most often that sense of Asian Americans as a model minority has come from two things. One is that I think the average American's interaction with Asian Americans has tended to be with Asian Americans who have immigrated here post 1965, who were in that wave of sort of, kind of higher income, more highly educated groups. But the other is to, for me, showing the disaggregated data and really making the point that what we know about Asian Americans in the aggregate is very different about what we know about Asian Americans when we look at particular subgroups. But then also, I think to really underscore, their immigrant experience, and their experience with facing challenges around limited English proficiency, their experiences with discrimination. So I really think we have to address the kind of historical context of how they're coming here. But yeah, I think it's really it's a hard challenge to address in the moment. And I think when we think about research, it's really a pervasive problem at every level, So still to this day, I feel like I have to really, if I submit a grant, for example, I really have to hammer in the case to the study section that, South Asians, for example, in my work, South Asians face cardiovascular disease disparities. At this point, that shouldn't even really be a question. There's like such an established body of literature around that. But I think that we as a community, I think, like many minoritized communities, but there's a particular sort of issue that Asian Americans face. We face a lot of stereotypes. And so our data has to kind of fight up against that.
Thank you. I just have a comment about, about cancer and heart disease and that thing. So if you look at our populations back home, only in the last 10 years where there's been a spurt of obesity and there is more prosperity, there's a bigger middle class and a bigger upper class, that you're noticing these. So some of us who came away many years ago never saw this happening in our own population. So we don't think, I'm supposed to get a colonoscopy, but I say, oh no, this doesn't happen in our community. I'm not going to get a colonoscopy. It's something that's alien to us, of getting a colon cancer. So uncommon, unrare. So it's a rare issue. And that's, I think, where the problem is. So it's not that we are not coming into research. We are also not seeking those tests or that thing that anybody here would normally go and get their colonoscopies done above a certain age. But it's not something that's ingrained into us as we were in those countries when this was not prevalent. And I think that's where some of the problem lies. I mean, this is just my observation.
Yeah, absolutely. I mean, I definitely think there is an element that is related to kind of community knowledge and education. But I think what's interesting and it's why I showed some of the data on kind of systems and provider level, even when we know, for example, I think most Asian Americans know that, there are high rates of diabetes in our community. But we see that even within that context, providers are less likely to recommend the kind of standard of care. They're less likely Asian Americans are less likely to get screened, for example, for diabetes. So I think it's operating at multiple levels. But certainly, and that's why in our interventions, kind of community education and really culturally tailored health education has been a really important piece of that. I think particularly around cancer screening, which has some other challenges, right? There's a lot of stigma associated with cancer diagnosis. There's a lot of fear. There are financial consequences, for cancer diagnoses, particularly among uninsured populations. So.
Well, if I could just say, outstanding presentation. I'm so grateful that you've assumed this leadership role around research for the API community, not only in New York City, but really standing up for communities across the country. Renee, I know is going to tell you this, but the content that you provided would make a great submission to Medit portal as we talk about, you've already done the hard work. The presentation is exceptional. We don't have much curricula that's been published in the Journal of Medit portal that ties to API identity. Not to put more work on your plate.
No, it's a great thought.
Maybe with some of your college and post-bac trainees to submit something, and definitely reach out to me. I'm the associate editor, one of the associate editors.
Okay, I definitely will. That's a great idea. I mean, I have 4 different medical students in particular working with me this summer, and I think it would be a great project for them. And I'll reach out to Renee right after this. And she actually works with us on one of our projects around H. pylori screening for Asian American communities. So, great. Well, again, thank you for the invitation. I do have to run. I know everybody's in back-to-back Zooms right now, but really appreciated the chance to talk to you all, and do stay in touch as well.
Thank you